Now we move to the next speaker, Dr. Mohammed, Dr. Alaa Abdelhamed. Dr. Alaa Abdelhamed. But Chiari syndrome presented with suprahepatic IVC occlusion, debate on management.
Bismillah ar-Rahman ar-Rahim. Mr. Chairman, dear professors and colleagues, I am sure everybody is exhausted and hungry, so I'll try to present my case in a rapid way. We have in this presentation a 17-year-old female patient previously diagnosed as having lupus erythematosus and presented with recurrent attacks of abdominal pain, fever, and vaginal bleeding for almost a period of 4 months. She sought medical advice where she was discovered to have also generalized lymphadenopathy with hepatosplenomegaly, and when the blood picture done at that stage, it reveals that she has decrease in all elements of blood, I mean hemoglobin, white blood cells, and platelets. She started to receive methylprednisolone on the basis that she has lupus erythematosus with pancytopenia, and they thought that the cause of pancytopenia is an activity of lupus erythematosus. She was referred to Qasr al-Aini at our center with persistent vaginal bleeding of large amount associated with blood clot and ecchymotic patches on both upper and lower limbs. On examination, the patient was fully conscious. Her weight and height and body mass index was within average. The blood pressure was 140/90, pulse was 90 per minute, and she has fever ranging between 37 and 39, intermittent fever. On head and neck examination, there was pallor, alopecia, and ecchymotic patches on both upper and lower limbs. On abdominal examination, it was surprisingly, we found multiple dilated tortuous veins on the lateral sides of the abdominal wall, filling from down upwards, and we have an enlargement of both liver and spleen. Also, we have these dilated veins on the chest wall, which fills also from down upwards. And as we clinically know that when we have a dilated veins on the lateral wall of the abdomen and over the chest wall filling from down upwards, it means that we have some sort of a inferior vena cava obstruction. So the problem list of this lady, that 17-year-old female with recurrent abdominal pain, bleeding tendency, pancytopenia, and hepatosplenomegaly. The lab on admission, we have anemia, hemoglobin 9.9 grams, and we have severe platelet deficiency. We have a platelet of 10,000 count, platelet count of 10,000. For the chemistry, we have no abnormality apart from raised LDH. And for the coagulation profile, we want to concentrate that this patient has an INR of 1.3, prothrombic concentration 59%, and we have also a prolongation of the PTT. We have 58 seconds for the PTT. Her sedimentation rate was high. Initially, the anti-nuclear antibody was negative, and we considered that because the patient received multiple doses of steroids, but the anti-double-stranded was positive. The anti-cardiolipin, IgM and IgG, was negative, and the complement level was consumed. On consultation for gynecology for this vaginal bleeding, they reveal that by ultrasound, this lady has a hemorrhagic cyst in the left ovary, the right ovary was normal, and they recommend to continue for proper analgesic, start oral progestin, and follow up after 3 months on outpatient basis. This is the 3D results. We do a bone marrow for this pancytopenia, which revealed increased megakaryocytes with no other interpretation. This patient with peripheral mycytopenia, splenomegaly tuberosum with bone marrow, they suggest bone marrow biopsy. They suggest that this pancytopenia is due to peripheral destruction rather than a disease in the bone marrow. The hospital course, she received immunosuppressants, and we decide, because of the low platelet count and there is no response on corticosteroids, to go to the rituximab. Rituximab is one of the biologic therapy. We use it in autoimmune diseases when there is resistance to the conventional treatment. On rituximab, the platelet started to rise, and we were faced with a platelet count finally of 87,000. She was kept on the immune suppressant drugs, and 1 week later, after this, she started to complain of jaundice, for which she was admitted with a bilirubin of 10.2 milligram and direct of 5.5. The liver enzymes were also high. At this stage, the ANA, the anti-nuclear antibody, was positive, and when we do the lupus anticoagulant screening for antiphospholipid antibodies, it was also positive, and still the complement consumed. But doing a pelvic abdominal ultrasound, they told us that they have an irregular hepatic veins suggestive of bad Chiari for CT venography, and the spleen was also enlarged. We do a hepatic duplex for this patient, and we have a mildly dilated hepatic veins that was painted with damped flow. The hepatic segment of the IVC was painted with mildly dilated caliber. And when we go to the suprahepatic segment, we find very much diffuse attenuation of the caliber with sharp increase in flow. Velocity was ratio was more than 2 compared to the hepatic segment. And we suggest that this diffuse attenuation with this high velocity might be either have a suprahepatic IVC stenosis, or this is a stump with increased velocity and we have an occluded IVC. On the CT venography, we have a complete obstruction of the suprahepatic portion. This is the segment. As we find here, we find a total occlusion of the suprahepatic segment of the IVC. This is again the segment. So we started anticoagulation with enoxaparin and warfarin. The total bilirubin started to drop, and the direct also. So what are the challenges we face in this case? Number one, this case was misdiagnosed at the first presentation because this case has dilated tortuous veins over the anterior chest wall and anterior abdominal wall, and nobody discovered the problem of her IVC. The second case is this lady has secondary antiphospholipid antibodies, and she presented with an episode of bleeding and thrombosis. Can both be explained by the same etiology or not? And what will be the treatment option in such a lady who will present with a bleeding and thrombotic episode? And what will be the proper management for this lady IVC thrombosis? This is the classification presented for the IVC and Chiari. The first is a partial obstruction of the IVC. The second is a total occlusion of a long segment of the IVC not involving the hepatic veins. And the third one is a total occlusion involving the hepatic veins. There are many therapeutic approaches: anticoagulant with warfarin, different thrombolytic agents, whether catheter directed or through peripheral intravenous route, balloon angioplasty and or stents, or portosystemic shunts, or the last option, which is the surgical shunt, and finally, the patient, if she developed a liver cell failure, the liver transplantation. They are very complicated. They have a high risk of causing bleeding and significant risk for pulmonary embolism. So the answer for such any challenges, antiphospholipid antibodies can present with both bleeding and thrombosis. And the reason for that is that antiphospholipid antibodies are a wide range of antibodies. Some of them can cause thrombosis. Some of them can be an antibodies to the prothrombin, to factor VIII, the clotting factors, and these also can cause bleeding. And the treatment is still the same for both. Even if antiphospholipid antibody syndrome present with bleeding and thrombosis, this will never tell us to stop anticoagulation. We have to give anticoagulation if these patients present with bleeding. Thank you.